Welcome to Bookfulness. This is episode 13 in our series, really digging deep into human anatomy.
That's right.
Last time, we focused on let's say, the cage, the thoracic wall, the ribs, muscles, all that structure.
Yeah, the container. And today we're punching through that wall, moving deeper inside.
Exactly. So we've got two main goals today, right?
Yep.
First, tackle the anatomy of the female breast, especially focusing on that clinically vital lymphatic drainage.
Absolutely crucial. And then
We transition into the thoracic cavity proper. We'll explore the pleurae, the lining, then the lungs themselves, and finally that intricate network, the tracheobronchial tree.
we're drawing heavily from the source material, specifically pages 575 through 607.
Right. Think of this as your detailed guide. We're not just listing parts. We want you to understand why these structures matter in, say, oncology, surgery, respiratory medicine.
Yeah, the clinical context is everything. We need to really unpack the details, not just skim the surface.
Okay, let's dive in. Starting with the female breast. The sources emphasize just how variable it is. Size, shape, symmetry. It changes a lot, doesn't it, based on age? Hormones.
Hugely variable, but the underlying footprint, the bed of the breast, is, well, generally more consistent. It's quite extensive.
How extensive are we talking?
Vertically, it usually stretches from the level of the second rib, way up high, down to the sixth rib.
Go second to sixth rib, that's a fair bit of territory, and side to side.
Horizontally, you're typically looking from the edge of the sternum, medially, right out to the mid-axillary line laterally. And, what's interesting and noted on page 575 is the difference in borders. Superiorly, up top, it tends to just blend into the chest wall, not a sharp line.
Ah, okay. But the bottom edge is different.
Much different. The inferior and lateral edges are usually quite well defined, often marked by what's called the inferior cutaneous crease.
That crease sounds important.
It is, especially surgically. It gives surgeons a natural line to hide incisions, making them less visible later on. Pretty clever, really.
Okay, so moving inward slightly. The nipple and areola were obvious landmarks. The nipple itself, that's where the lactiferous ducts open, right? For milk delivery.
Precisely. The functional exit points. But the really interesting anatomy, the support system, lies underneath.
You mean the ligaments?
Exactly. We have to talk about the suspensory ligaments of Cooper. These aren't just flimsy threads. They're strong, fibrous bands. They radiate out from the skin, the dermis, down deep to the pectoral fascia.
So they anchor the whole thing?
Essentially, yes. They support the glandular tissue, hold its shape, counteract gravity to some extent, purely structural.
And I remember reading about the clinical side of this. They're great for support, but they can also be, well, indicators of trouble.
That's the downside. When a carcinoma, a cancer, starts growing, it can invade these ligaments and shorten them. It pulls on the skin from the inside.
Creating that dimpling effect.
Exactly. That pitting or dimpling, sometimes called peau d'orange, like orange peel skin. It's a classic and unfortunately serious sign that the cancer is involving these supporting structures.
Okay. And then deeper still, just before we hit the muscle layer, there's that space, the retromammary space.
Or retromammary bursa, yeah. It's basically a layer of loose connective tissue.
Why loose? Is there a reason for that?
Oh, definitely. It's designed for movement. This loose plane sits between the back of the breast gland and the fascia covering the pectoralis major muscle.
So the breast can slide a bit.
Precisely. It allows the breast some freedom to move over the chest wall when you move your arm, or when the pec muscle contracts. It prevents it from being totally fixed.
But, like Cooper's ligaments, this space can become clinically significant too, right? In cancer?
Absolutely. It's another critical zone. If an aggressive cancer breaks through the back of the gland and invades this space, or worse, the pectoral fascia itself,
then the breast loses that mobility.
Exactly. It becomes tethered, fixed to the chest wall. And that loss of mobility is a major red flag during a physical exam, a really important diagnostic sign. Hashtag tag 1.2 neurovasculature and clinically vital lymphatic drainage.
All right, let's talk supply lines. The breast tissue, especially during lactation, must need a lot of blood. Page 583 outlines, three main sources?
Yeah, it's got a pretty robust arterial supply coming from different directions, essential for redundancy,
Makes sense. Where does it come from?
Okay, so medially, near the sternum, you get perforating branches from the internal thoracic artery, coming straight down.
Okay, internal thoracic medially. What about laterally?
Laterally, the main player is the lateral thoracic artery. It supplies the tissue that extends out towards the armpit, the axilla.
Got it. Medial lateral.
Yeah.
Is there a posterior source too?
Yep. From the back, you get contributions via the second, third, fourth, fifth, and sixth intercostal arteries. Those posterior branches feed in.
So a really comprehensive network.
Yeah.
Medial, lateral, and posterolateral inputs. And the veins, do they just follow the arteries?
Largely, yes. Venous drainage tends to mirror the arterial supply, flowing back into the internal thoracic veins and, importantly, the axillary veins. You might even see these veins become more prominent under the skin during pregnancy because of the increased blood flow.
Interesting. But while blood flow is vital for function, when we talk about disease spread, especially cancer, it's all about the lymphatics, isn't it? That seems to be the highway.
We absolutely cannot overstate this. The lymphatic system is the critical pathway for lymphogenic metastasis, the spread of cancer via lymph fluid. The sources are very clear on this. There's one dominant route.
Jesus.
Over 75%, think about that, more than 3/4 of the lymph, especially from the outer parts of the breast, drains directly into the axillary lymph nodes, under the arm.
Okay, so the axillary nodes are like the main checkpoint. But they're not just one single node, are they? It's a whole group.
Exactly. It's a complex network. Surgeons and pathologists categorize them into different levels based on their position relative to the pectoralis minor muscle. You have level 1, level 2, and level 3 nodes.
And the level matters clinically.
Immensely. Finding cancer cells in level I nodes, lowest, most lateral, is significant. But finding them in level 3 nodes, highest, near the clavicle, indicates much more expensive spread. It directly impacts staging and treatment planning. Sentinel node biopsy, for instance, tries to identify that very first node the cancer drains to.
Right, the sentinel node. Okay, so 75% plus goes to the axilla. But what if that main highway is blocked, say, by tumor cells, or removed during surgery? Does the lymph just back up?
It can back up, leading to swelling, but it also tries to find alternative routes. The lymphatic system has abundant connections, these sort of collateral pathways.
Where do they lead?
Well, lymph can track medially towards the sternum into the peristernal nodes, sometimes called internal mammary nodes, or it can go upwards towards the collarbone into the infraclavicular and supraclavicular nodes.
So spread can go up or medially anywhere else?
Yeah, it gets worse. There are connections that allow spread across the midline to the opposite breast, or it can track downwards inferiorly towards lymphatics in the abdomen. It's quite pervasive.
That covers the lymphatic spread. But then there's the other route, the venous route. The sources mention this as a particularly dangerous pathway for metastasis, bypassing the lymph nodes.
Well, it's a chilling piece of anatomy, frankly. It involves how the veins draining the chest wall connect deep inside.
How does that work?
Some of the venous blood from the breast drains into the posterior intercostal veins. These veins run along the ribs and eventually empty into the azygos and hemiazygos system.
Okay, that's the big venous system running alongside the spine, right?
Exactly. And the critical, dangerous connection is that the azygos system communicates directly and extensively with the internal vertebral venous plexus.
Ah, the network of veins around the spinal cord.
Yeah.
And those lack valves, don't they?
Precisely. Valveless. This is key. It means blood can flow in either direction. So if cancer cells get into the venous system from the breast or chest wall, maybe the tumor erodes into a small vein, they can get shunted into this vertebral plexus.
And because there are no valves,
changes in pressure inside the abdomen or chest, like from coughing, straining, even just breathing deeply, can push those cells upwards against gravity along the spine.
leading to
Metastasis in the vertebrae. It's incredibly common for breast cancer to spread to the bones of the spine. And crucially, this plexus also communicates upwards into the skull.
So a direct route to the brain.
A direct venous pathway from the chest wall, potentially, right into the cranium and the brain. It bypasses many of the body's usual filtering systems. It's a direct, terrifying conduit. #tag 1.3 surface anatomy of the thoracic wall. Okay, so before we actually dive inside the chest cavity to look at the lungs and pleura, we need to orient ourselves. All this talk of internal structures is useless without a map on the outside. We need that shared framework.
Right, surface anatomy. Being able to pinpoint things based on what you can see or feel on the chest wall.
Yeah.
Where do we start? What's the key landmark?
Yeah, the most obvious and easily palpable one right in the midline is the sternal angle, also called the angle of Louis.
You can feel that little bump where the top part of the sternum, the manubrium, joins the main body, right?
Exactly. Just run your finger down the manubrium and you'll feel it. And anatomically, this point is gold. It sits precisely at the level of the intervertebral disc between the T4 and T5 vertebrae.
T4, T5. Why is that level so significant? It defines a plane, doesn't it?
It defines the transverse thoracic plane. This horizontal plane acts like a major anatomical crossroads inside the chest. So many critical events happen right at this level, as mentioned on page 598.
Like what?
Well, for starters, it's where the trachea bifurcates, splits into the right and left main bronchi. It's also where the arch of the aorta begins and ends, and it marks the superior limit of the pericardium, the sac around the heart.
Wow. So knowing the one external bump tells you a lot about the internal layout.
A huge amount. If you know the sternal angle, you know T4, T5, and you can mentally map a whole lot of structures relative to that.
Okay, that's the midline. What about moving laterally? We use reference lines, right?
Yeah.
Lines of longitude, as the source calls them.
Correct. We need vertical lines for reference. The most straightforward is the anterior median line, AML, or midsternal line, running right down the middle of the sternum.
Easy enough. What's next?
The midclavicular line, MCL, this one's really important clinically. You find the midpoint of the clavicle, the collarbone, and drop a vertical line straight down.
And we use that for?
All sorts of things. Locating the apex beat of the heart, for example, usually around the 5th intercostal space on the left MCL. Assessing liver size. Describing locations of sounds during auscultation. It's a workhorse line.
Okay. AML, MCL, and then further out towards the side, under the arm.
Yeah, then we use lines based on the axilla, the armpit. There are 3. The anterior axillary line running down in the anterior axillary fold, the posterior axillary line from the posterior fold, and right between them, the mid-axillary line.
So, if a clinician describes a finding,
they need to be precise. They'll say something like, dullness to percussion in the 8th intercostal space, mid-axillary line. And that description has to mean the exact same spot to everyone reading the notes. Without these lines, describing internal anatomy is just vague. This provides the necessary grid reference.
Okay, we've got the structure, the blood supply, the lymphatics, the surface map. Now let's tie it all together clinically. Page 583 has a great clinical box. Let's start with the quadrants. Why do we divide the breast into quadrants for clinical purposes?
It's purely for localization. Makes it much easier to describe where a lump or pain or skin change is located. You imagine lines crossing at the nipple, horizontal and vertical, dividing it into 4. Superior lateral, superior medial, inferior lateral, and inferior medial.
And is there one quadrant where problems, specifically tumors, are more common?
Oh, definitely. The statistics are quite clear. The superior lateral quadrant, the upper outer section, is far and away the most common site for breast cancer to originate.
Really? Why there specifically? Is there an anatomical reason?
There are a couple of contributing factors. First, it simply contains the largest volume of glandular tissue. More tissue statistically means more chances for something to go wrong.
Makes sense. Anything else?
Yes. And it relates to the axillary process or tail of the breast. This is a significant chunk of glandular tissue that extends from the superior lateral quadrant up and out towards the axilla. So you've got extra tissue volume there. Plus, geographically, it's closest to those main axillary lymph nodes we talked about.
Proximity to the main drainage route. Okay, now let's circle back to that clinical sign involving the retromammary space invasion. You mentioned a test.
Right, the test involving the pectoralis major muscle. It's a way to check if the cancer has become fixed to the deeper structures.
How does it work again?
You ask the patient to contract their pectoralis major muscle, usually by having them press their hands firmly against their hips. Now, a normal breast with its loose retromammary space will move freely over the contracting muscle.
But if the cancer has invaded that space, or the fascia,
then the breast tissue is essentially tethered down. When the muscle contracts, instead of moving freely, the breast might elevate unnaturally, or dimple, or just look distorted because it's stuck. It confirms deeper invasion, a sign of more advanced local disease.
A very direct way to assess that mobility. Okay, shifting gears slightly. Treatment often involves dealing with those axillary lymph nodes, right? Surgery or radiation. What's the major consequence of disrupting that lymphatic highway?
The big one is ipsilateral lymphedema. Ipsilateral meaning on the same side as the treated breast.
Lymphedema, that's swelling, isn't it?
Chronic, often debilitating swelling of the arm. Remember, those axillary nodes don't just drain the breast. They drain the vast majority of the lymph fluid from the entire arm on that side, too.
Ah, I see. So if you remove them or damage them with radiation.
You essentially remove the arm's main drainage system. Lymph fluid can't get back into the circulation effectively, so it backs up in the tissues of the arm.
Causing the swelling.
Causing chronic swelling, a feeling of heaviness, tightness, increased risk of infection. It can significantly impact quality of life for survivors. It's a direct anatomical consequence of necessary cancer treatment.
A tough trade-off.
Nah.
Lastly, on the clinical side, even for less serious things like biopsies, surgeons think about the anatomy for cosmetic reasons, right? Incision placement.
Absolutely. Minimizing visible scarring is always a goal. The sources mention a couple of common strategies on page 583. Often, incisions are made radially, sort of like spokes on a wheel pointing towards the nipple, following natural skin tension lines. Or, perhaps even more commonly, they use that inferior cutaneous crease, the fold underneath the breast. Placing the incision there hides it very effectively in the natural contour. Hashtag tag 2.2, Introduction to the Thoracic Viscera and Pleurae.
Okay, we've thoroughly mapped the breast and the chest wall. Now let's finally push through that fascia and enter the thoracic cavity itself. What's the basic layout inside? How is it divided?
Fundamentally, the thoracic cavity is divided into 3 major compartments as laid out on page 589.
3.
You have 2 large, separate pulmonary cavities, one on the right side and one on the left. Each of these completely contains one lung and its associated pleura.
So a cavity for each lung. What's the third compartment?
The third is the central region, sandwiched between the 2 pulmonary cavities. This is the mediastinum.
Ah, the mediastinum. That contains the heart, doesn't it?
The heart, yes, plus its sac, the pericardium, but also the great vessels aorta, pulmonary trunk, vena cava, the trachea, the esophagus, major nerves like the phrenic and vagus. It's a very crowded, vital central corridor.
And it acts as a partition.
A crucial partition. It separates the right and left pulmonary cavities. This is important clinically because it means, for instance, a collapsed lung, pneumothorax, or an infection in one cavity usually stays confined to that side. The mediastinum prevents it from immediately affecting the other lung.
Okay, partitions make sense. Now let's talk about the lining of those pulmonary cavity and the lungs themselves, the pleurae. I always think of the fist in a balloon analogy here.
It's genuinely the best way to visualize it. Imagine you have a large, slightly deflated balloon. That's the pleural sac.
Okay.
Now, push your fist, representing the developing lung, into the side of the balloon. Your fist gets completely enveloped by the balloon rubber, right? But your fist never actually enters the air-filled space inside the balloon.
Right, it just pushes the balloon wall inwards.
Exactly.
Yeah.
And in doing so, you create 2 layers of balloon material right next to each other, separated by only a potential space.
Those 2 layers are the pleurae.
Precisely. The layer of balloon that's stuck directly onto your fist, the lung, is the visceral pleura. It's thin, shiny, and inseparable from the lung surface itself. It even dips down into the fissures between the lung lobes.
Okay, visceral means organ-related. So the visceral pleura is on the lung. What's the outer layer?
The outer layer, the part of the balloon still lining the inside of the chest wall, the diaphragm and the mediastinum, is the parietal pleura. Parietal means relating to the wall of a cavity. This layer is thicker and can be surgically separated from the structures it lines.
Got it. Visceral on the lung, parietal lining the cavity, and the space between them.
That's the pleural cavity.
Yeah.
And it's crucial to understand it's a potential space, not an actual open gap in health.
Potential space, meaning?
Meaning, normally, the visceral and parietal pleurae are right up against each other, separated only by a tiny microscopic film of pleural fluid, maybe just a few milliliters.
What does that fluid do?
2 incredibly important things. First, it acts as a lubricant, allowing the lungs to glide smoothly against the chest wall during breathing, minimizing friction.
Okay, lubrication. What's the second thing?
Surface tension. The inherent attraction between the fluid molecules and the pleural surfaces creates a force that effectively sticks the visceral pleura on the lung to the parietal pleura on the chest wall.
Why is that stickiness so important?
Because the lung tissue itself is naturally elastic, it wants to recoil inwards and collapse like a stretched rubber band. This surface tension, coupling the lung to the chest wall, counteracts that elastic recoil. When your chest wall expands outwards during inhalation, it pulls the parietal pleura, which pulls the visceral pleura, which pulls the lung open. Without that fluid link, the lung would just collapse. Hashtag 2.3 regions of parietal pleura and clinical recesses.
Okay, that makes sense. The parietal pleura lines the whole cavity wall. Do we give different names to different parts of it depending on what it's touching? Page 592 mentions named parts.
Yes, we subdivide the parietal pleura based on its location. It makes anatomical descriptions more precise. There are 4 main parts.
4 parts. Let's list them.
First, the largest part is the costal pleura. This lines the inner surface of the ribs, the costal cartilages, the intercostal muscles, basically the whole rib cage wall.
Okay, costal for ribs. Next.
Then you have the diaphragmatic pleura, which covers the superior or thoracic surface of the diaphragm muscle at the base of the cavity.
Makes sense. Covers the diaphragm. Third.
The mediastinal pleura. This forms the lateral boundary of that central compartment, the mediastinum. It reflects over the structures at the root of the lung, the bronchi, vessels, etc.
Costal, diaphragmatic, mediastinal was the fourth. It extends upwards, doesn't it?
That's the one. The cervical pleura, sometimes called the cupola, this is the dome-shaped part that extends superiorly through the superior thoracic aperture into the root of the neck.
So it actually pokes up above the first rib?
It does, yeah. Reaches a few centimeters above the level of the first rib and clavicle. Because it's relatively exposed up there in the base of the neck, it's reinforced by a thickening of fascia called the suprapleural membrane, giving it some extra protection.
Interesting. Okay, so that covers the lining. Now, you mentioned the pleural cavity as a potential space, but the lungs don't perfectly fill every single corner of the pulmonary cavities, especially during quiet breathing, right? This leaves some gaps or recesses.
Exactly. These are potential spaces where opposing surfaces of parietal pleura touch each other, but the lung doesn't normally extend into them during quiet breathing. They are reserved spaces for lung expansion during deep inhalation.
Are these recesses clinically important?
Extremely important, particularly one of them, the costodiaphragmatic recess.
The costodiaphragmatic, so between the ribs and the diaphragm.
Precisely. It's the deep gutter down at the very bottom periphery of the pleural cavity where the costal pleura reflects sharply onto the diaphragmatic pleura. Think of it as the angle where the side wall meets the floor.
And why is that one so critical?
Gravity. When a person is standing or sitting upright, this recess is the lowest point in the pleural cavity.
So any abnormal fluid that collects in the pleural space
is going to pool there first, whether it's pleural effusion, serious fluid, often from heart failure or inflammation, hemothorax, blood from trauma, or pyothorax embolyema, pus from infection. It accumulates down in the costodiaphragmatic recess.
And that fluid can compress the lung, right? Prevent it from expanding properly.
Absolutely. A large effusion can significantly compromise breathing, which leads us directly to why we need to be able to access that fluid.
You mean for thoracentesis?
Yeah.
Draining the fluid.
Or just sampling it for diagnosis, yeah. Thoracentesis is inserting a needle into that pleural cavity, specifically targeting the costodiaphragmatic recess to get that fluid out. Page 607 has a good illustration.
Okay, so how do you do it safely? What's the anatomical logic behind the procedure?
There are three key anatomical considerations. First, the location. You typically aim for the 9th intercostal space in the mid-axillary line.
9th base mid-axillary line, why there?
It's usually well below the inferior border of the lung during normal breathing, ensuring you're likely in the recess. And it's far away from the heart and major vessels. Gives you a good safety margin.
Okay. Location. What else?
Second, timing relative to breathing. You usually perform the procedure during expiration.
During exhale.
Because when you exhale fully, the diaphragm rises and the lower border of the lung moves upwards, making that costodiaphragmatic recess even larger. It maximizes the fluid-filled space available and pushes the lung further away from your needle tip.
Smart. Increase the target zone, move the delicate lung out of the way. What's the third rule? Something about the ribs.
The absolute cardinal rule. Always insert the needle immediately superior to the rib margin that forms the lower border of the intercostal space you've chosen. So aim just over the 10th rib if you're in the 9th space.
Why specifically above the rib?
Because the intercostal nerve, artery, and vein, the neurovascular bundle, VEN, run in a groove, the costal groove, along the inferior edge of the rib above. If you go just below the 9th rib, you risk hitting the 9th intercostal bundle. Going just above the 10th rib keeps you clear of both the 9th and 10th bundles. Hitting those vessels can cause serious bleeding. Hitting the nerve causes pain.
Got it. Aim high in the space, over the lower rib. Okay, one last point on pleura. Sensation. We talked about referred pain earlier. Is there a difference in how the two pleural layers feel pain?
Big difference. And it's clinically very relevant. The visceral pleura, the layer right on the lung surface, gets its nerve supply from the autonomic pulmonary plexus. It's sensitive to stretch, but largely insensitive to touch, temperature, or sharp pain. You could, theoretically, cut the visceral pleura without the patient feeling sharp pain.
Okay, visceral is insensitive. What about the parietal layer?
The parietal pleura is the opposite. It's richly supplied by somatic sensory nerves and is extremely sensitive to pain, temperature, touch, and pressure. Inflammation of the parietal pleuritis, or pleurisy, causes sharp localized pain.
And which nerves supply it?
It depends on the region. The costal pleura and the peripheral part of the diaphragmatic pleura are supplied by the intercostal nerves corresponding to those regions. So irritation there causes pain felt directly in the adjacent chest wall.
Okay, intercostals for the periphery. What about the central part?
The central part of the diaphragmatic pleura and the mediastinal pleura are supplied by the phrenic nerve, which arises from C3, C4, C5 spinal segments in the neck.
Ah, and that's the key to referred pain, isn't it? Phrenic nerve irritation.
Exactly. If you have inflammation irritating the central diaphragmatic or mediastinal pleura, the pain signals travel up the phrenic nerve to the C3, C5 spinal cord levels. The brain can misinterpret these signals as coming from the dermatomes supplied by C3, C5, which include the skin over the shoulder area. So central pleuritis can cause referred pain felt acutely in the shoulder tip.
All right, we've explored the cavity and its lining. Now let's finally get to the main event inside those pulmonary cavities, the lungs themselves, the core organs of respiration. And this is where the differences between the right and left sides really stand out.
They do indeed. While both lungs share some general features, their specific shapes and divisions are quite distinct, largely dictated by the surrounding structures, especially the heart.
What are the common features?
Both lungs have a blunt superior end called the apex, which actually extends up into the root of the neck above the first rib. Remember, the cervical pleura covers it.
Right, the apex goes high. What about the bottom?
The inferior surface is concave and called the base. It rests snugly on the convex dome of the diaphragm. And both lungs have a medial surface featuring the hilum.
The hilum, that's the gateway we talked about, where structures enter and exit.
Exactly. The region on the mediastinal surface where the bronchi, pulmonary arteries, veins, nerves, and lymphatics collectively form the root of the lung as they pass into or out of the lung substance. Page 595 shows this well.
Okay, apex, base, hilum, common to both. Now let's look at the differences. Tell us about the right lung first.
The right lung is typically a bit larger and heavier than the left. Interestingly, it's also usually shorter and wider.
Shorter. Why shorter?
Because the right dome of the diaphragm sits higher up in the thorax to accommodate the large liver underneath it in the abdomen. So the base of the right lung is pushed up higher.
Ah, the liver's influence. And structurally, how is the right lung divided?
The right lung is divided into 3 lobes: a superior lobe, a middle lobe, and an inferior lobe.
3 lobes on the right.
Right?
What separates them?
2 deep fissures. The oblique fissure separates the inferior lobe from the middle and superior lobes, and the horizontal fissure separates the superior lobe from the middle lobe. So 3 lobes, 2 fissures.
Got it. Right lung. 3 lobes, 2 fissures, oblique and horizontal. Now the left lung, it has to make room for the heart, right?
That's its main distinguishing feature, yes. The left lung is generally smaller, narrower, and only has 2 lobes: a superior lobe and an inferior lobe.
Only 2 lobes on the left, so only 1 fissure then.
Correct. Just a single, large oblique fissure separating the superior and inferior lobes.
And because the heart bulges over to the left.
The left lung has a distinct indentation on its anteromedial aspect called the cardiac notch. This accommodates the apex of the heart.
Cardiac notch on the left. And there's another unique feature on the left lung too, isn't there? Something called the lingula.
Yes, the lingula. It's a small, tongue-like projection of the superior lobe that extends downwards, just below the cardiac notch.
What is the lingula anatomically?
It's generally considered the developmental equivalent, or homologue, of the middle lobe of the right lung. But functionally and anatomically, it's part of the left superior lobe. Clinicians need to remember that when interpreting imaging or planning procedures.
Okay, quick recap. Right lung, 3 lobes, 2 fissures. Left lung, 2 lobes, 1 fissure, plus the cardiac notch and the lingula. Clear differences. Hashtag tag 3.2, the branching tracheobronchial tree.
So having the lungs is great, but they're useless without a way to get air into them. That's the job of the tracheobronchial tree.
Starting with the windpipe, the trachea, supported by cartilage rings, right?
Yes. C-shaped rings of hyaline cartilage that keep it from collapsing.
Oh.
Open posteriorly where the esophagus sits, the trachea descends down the neck and into the thorax until it reaches that critical division point we mentioned earlier.
The bifurcation, happening at the level of the sternal angle, T4, T5, the transverse thoracic plane.
Exactly. And here, the asymmetry between right and left becomes incredibly important clinically.
How so?
At the bifurcation, the trachea splits into the right and left main, or primary bronchi, but they are not symmetrical. The right main bronchus is significantly wider, shorter, and runs more vertically downwards than the left.
Wider, shorter, more vertical on the right and the left.
The left main bronchus is narrower, longer, because it has to pass under the aortic arch, and deviates more sharply to the side, more horizontally.
And this difference in angle and width has a major consequence if someone aspirates something, right? Like a kid swallowing a small object.
Huge consequence. Physics takes over. If you inhale a foreign object, a peanut, a small toy part, whatever gravity and airflow dynamics mean, it's far more likely to follow the path of least resistance.
Which is the right side.
Which is the wider, more vertical right main bronchus. So aspirated foreign bodies almost always end up lodged in the right bronchial tree, not the left. Knowing this directs diagnostic imaging and bronchoscopy procedures immediately. It's a classic anatomical correlation.
Makes perfect sense. Now, right at that bifurcation point, there's a specific structure, the carina.
Yes, the carina. It's a sharp, keel-shaped ridge of cartilage internally, right where the trachea divides, covered in respiratory mucosa.
What's its significance?
It's loaded with sensor receptors. It's probably the most sensitive area in the larynx or trachea for triggering the cough reflex. Touching the carina during bronchoscopy, for example, provokes a very strong cough. Also, clinically, if imaging shows the carina looking blunted or widened, it can suggest underlying pathology, like enlarged lymph nodes between the bronchi pushing it apart, perhaps due to cancer.
A sensitive trigger point and a diagnostic clue. Okay, let's follow the branching pattern down from the main bronchi.
It's a hierarchical system. Each main primary bronchus enters the hilum of its respective lung and then divides into secondary or lobar bronchi.
One for each lobe.
Exactly. So the right main bronchus gives off 3 lobar bronchi, superior, middle, and inferior. The left main bronchus gives off 2, superior and inferior.
Okay, primary to secondary lobar. What's next?
The secondary, lobar bronchi, then further divide into tertiary or segmental bronchi. And these are fundamentally important because each one supplies a specific independent region of the lung.
This is where the concept of the bronchopulmonary segment comes in, right? Mentioned on pages 598 and 607. This is a really key concept.
Absolutely fundamental. Every student needs to grasp this. A bronchopulmonary segment is the largest subdivision within a lung lobe. Crucially, it's defined as the distinct anatomical and functional unit of lung tissue supplied by its own tertiary segmental bronchus and its own accompanying branch of the pulmonary artery, a tertiary segmental artery.
So each segment has its own air pipe and its own functional blood supply pipe.
Precisely. And they run together into the center of that segment. Importantly, the segments are separated from each other by connective tissue septa.
And the clinical payoff of this organization? Why is it so important for surgeons?
Because each segment is relatively self-contained, its air supply and arterial blood supply are independent of its neighbors, it means a segment is the smallest, functionally independent unit of the lung that can be surgically resected.
Smallest resectable unit, meaning?
Meaning if a disease process, like a localized cancer or a chronic infection, is confined to a single segment, a surgeon can potentially remove just that segment, a segmentectomy, while preserving the function of the adjacent healthy segments in the same lobe. This allows for lung-sparing surgery, which is often preferable to removing an entire lobe, lobectomy, or the whole lung, pneumonectomy. This segmental anatomy makes it possible. Hashtag 3.3, vasculature and innervation of the lungs.
Okay, that segmental structure is elegant. Let's talk more about the blood vessels now. Page 601 mentions a dual blood supply to the lungs. That can be confusing. Can you clarify the two systems?
Yeah, it trips people up sometimes. You have to keep the two circulations separate in your mind. First, there's the pulmonary system. This is the functional circulation, the one involved in gas exchange.
Functional meaning for the body's overall oxygenation.
Exactly. The pulmonary arteries branch off the pulmonary trunk from the right ventricle, and they carry large volumes of low oxygen, CO2-rich blood to the lungs. This blood flows through capillaries surrounding the alveoli, picks up oxygen, drops off CO2.
And then returns to the heart.
Then the now oxygen-rich blood collects in the pulmonary veins, usually 2 veins leaving each lung hilum, which carry this bright red blood back to the left atrium of the heart, ready to be pumped out to the rest of the body.
So in the pulmonary circuit, arteries carry blue blood away from the heart, and veins carry red blood towards the heart, the opposite of the systemic circulation.
Precisely. That's the functional gas exchange loop. But the lung tissue itself, the walls of the bronchi, the connective tissue, the visceral pleura, they need their own nutritive blood supply, just like any other organ.
So that's the second system.
That's the bronchial system. This is part of the systemic circulation. Small bronchial arteries branch off, usually from the thoracic aorta, or sometimes from the posterior intercostal arteries.
And they carry oxygenated blood.
Yes. They carry oxygenated systemic blood to the supporting tissues of the lungs, the bronchi walls down to the level of the respiratory bronchioles, the connective tissue septa, the visceral pleura. They keep the lung structure itself alive.
Where does the bronchial venous blood drain?
Mostly, it drains into the pulmonary veins, mixing slightly with the freshly oxygenated blood returning to the left atrium. A smaller amount might drain into the azygosystem via bronchial veins.
Okay, dual supply. Pulmonary for gas exchange, bronchial for lung tissue nutrition. Now, within the lung, how do these vessels relate to the airways, especially within those bronchopulmonary segments?
There's a crucial relationship here, especially for surgeons. As we said, the tertiary segmental bronchus and the tertiary segmental pulmonary artery branch enter the segment together and run roughly in parallel through the center of the segment. They are paired.
Okay, artery and bronchus run together centrally, segmentally. What about the pulmonary veins draining the oxygenated blood out?
The veins are different. The tributaries of the pulmonary veins tend to run in the connective tissue septa between the segments. They are intersegmental.
Intersegmental, meaning they drain adjacent segments.
Yes, a vein lying in the septum between two segments will receive oxygenated blood from both of those segments.
And that has surgical implications too.
Absolutely. When a surgeon is performing a segmentectomy, they can identify and ligate, tie off the specific segmental artery and bronchus going into the target segment. Because the veins run in the septa at the periphery, they are less likely to be damaged and can be preserved to continue draining the adjacent remaining segments. That intersegmental venous drainage is key to making segmentectomy viable.
Very neat anatomical arrangement. Let's quickly revisit the lymphatics of the lungs before we finish. We mentioned asymmetry with the breast drainage. Is it complex for the lungs too? Page 607 touches on this.
It is somewhat complex, and yes, there's a degree of asymmetry again, particularly involving the left lower lobe.
How does it generally work?
Lymph from the lung tissue drains first to intrapulmonary nodes, then towards the hilum into the bronchopulmonary hilar nodes, and then upwards along the trachea to the tracheobronchial nodes, superior and inferior, including those around the carina. From there, it goes into lymphatic trunks that eventually drain into the venous system.
Okay. And the asymmetry?
Most of the lymph from the entire right lung follows a path up the right side of the trachea. Most of the lymph from the superior lobe of the left lung drains up the left side. However,
The left inferior lobe.
the majority of the lymph from the left inferior lobe often crosses over the midline to drain into the right superior tracheobronchial nodes.
Wow. So a tumor in the lower part of the left lung could potentially metastasize to lymph nodes on the right side of the trachea.
Correct. It means surgeons and oncologists evaluating a left lower lobe cancer need to assess the lymph nodes on both sides of the mediastinum. You can't just assume it stays on the left.
Good clinical point. Finally, innervation. What controls the airways constriction, dilation, mucus?
It's regulated by the autonomic nervous system via the pulmonary plexuses, which are networks of nerves surrounding the roots of the lungs, receiving input from both sympathetic and parasympathetic systems.
Parasympathetic first. Which nerve? What does it do?
Parasympathetic supply comes from the vagus nerve, CNX. Its effects are generally excitatory to the airway, smooth muscle, and glands. So it causes bronchoconstriction, narrowing airways, and stimulates mucus secretion, secretomotor.
Okay, vagus causes constriction and secretion. What about the sympathetic input?
Sympathetic fibers come from the sympathetic trunks. They are generally inhibitory to the bronchial muscle and glands, so they cause bronchodilation, relaxing airway smooth muscle, opening airways, and inhibit glandular secretion. They also cause vasoconstriction of the pulmonary blood vessels, although the regulation of pulmonary vasculature is complex.
So a balance between vagal bronchoconstriction and sympathetic bronchodilation helps regulate airflow.
Exactly. And there are also visceral afferent fibers traveling back with both systems, carrying sensory information like stretch from the alveoli or irritation signals that trigger reflexes like coughing from the carina and elsewhere, although again, the lung parenchyma itself isn't sensitive to sharp pain. #tag outro. You know, when you step back and look at all this detail, the precise segmentation of the lungs, the intricate mapping of the breast's lymphatic drainage, it really underscores a core principle, doesn't it?
Like that.
That this foundational anatomy isn't just academic knowledge for exams. It directly, absolutely dictates how modern medicine works. Procedures like segmentectomy, sentinel node biopsy, targeted radiation, they're only possible, only safe, because we understand this level of structural detail. Anatomy enables the technique.
That's a great point. It's a blueprint for intervention. So today, we really have done a deep dive. We started with the female breast structure, variations, the critical vascular and lymphatic pathways. Then we mapped the thoracic wall with surface anatomy landmarks. And then we moved inside, exploring the pleurae, using that fist and balloon idea, defining the cavity and recesses. We detailed the lobes and fissures of the asymmetrical right and left lungs.
And finished with the branching tracheobronchial tree, highlighting that crucial right main bronchus asymmetry and the concept of the bronchopulmonary segment, plus the dual blood supply and innervation, all drawn from pages 575 to 607 of the source.
A lot of ground covered.
Definitely. So here's something to mull over, a provocative thought connecting back to that pleural innervation we discussed.
Okay, let's hear it.
We know the parietal pleura is sensitive to pain. If a patient has pleuritis, inflammation of that lining, we expect pain over the affected area if it's the costal pleura supplied by intercostal nerves. But why, specifically, might inflammation irritating the central part of the diaphragmatic pleura cause sharp localized pain referred way up to the tip of the shoulder?
It's about that referred pain mechanism again. The hint is the nerve supply to that central diaphragm.
Exactly. Think about which nerve supplies it, the phrenic nerve, and think about the spinal cord levels the phrenic nerve comes from, C3, C4, C5.
Which also happen to supply sensation to the skin over the shoulder.
Bingo. The brain gets signals from C3, C5 via the phrenic nerve due to diaphragmatic irritation, but it interprets those signals as coming from the more common C3, C5 input source, the shoulder dermatome, a classic example of referred pain based purely on shared spinal segments.
Fascinating stuff. Okay, so where are we heading next time?
Next time, we stay inside the chest, but shift our focus squarely to that central compartment we introduced today. We're going to dissect the mediastinum in detail, its boundaries, its subdivisions, and we'll begin our exploration of the heart's protective covering, the pericardium.
Excellent. From the container and its contents to the very central core structures. Looking forward to it.
Me too. It's the engine room.
Thanks for listening to Bookfulness.